My job today is to go through the relive of a disc surgery, simple disc surgery. We have a 22-year-old male, history of working out in a gym, obese, chronic smoker. SLR on the right side was 40 degrees. Plantar flexion weakness by about 3/5. Sensory hypoesthesia in the S1 nerve root. Mildly diminished right ankle reflex, and X-ray shows the loss of disc height at L5-S1. No instability on flexion extension views. If you were to go by NAS's guideline, this would go into a T-lift case. But the window is quite large. We have an opportunity to do something. So here's the flexion extension views, and you can see that there is no instability as such. There's a large herniation of a disc, quite in the center and more towards the right. A small amount of ossification is also seen in the annulus of the disc. So let's begin with the relive surgery. We keep the patient in a prone position. We mark the midline after the draping is completed. And what you see over here is me marking the midline. And then I'll be marking across the patient's back. Exact level of the disc that I wish to be targeting. After that, I have to mark my pedicles. It's a biportal endoscopy, so you need 2 ports. 1 port for the scope, 1 port for the instrument, right? So the port that comes for the scope normally comes from below the superior pedicle. But in this case, because there is a collapse of disc height, and the lower port is what I am aiming to bring up, just above the S1 pedicle. Therefore, I've taken the port for the instrument portal a little higher, cutting mid-pedicular, so that I don't get a clash of instruments when I'm working on top. The scope can adjust in its vision, but the working instrument cannot. Then you mark the medial pedicular line, and then I personally prefer to use, not depend upon markings in the skin, I prefer to use 2 long spinal needles, triangulate on the superior lamina, and then infiltrate about 5 to 10 cc's of saline adrenaline with a little bit of local also in it, because that brings down the requirement of the anesthetic for the anesthesia person. And you'll see that when the triangulation is nice, fluid just pours out from one side or the other side, wherever you are injecting. Inject the track also, so that you have less bleeding, less issues, less headaches. Wait for some time. Give time for the local and things to act. And then we start with marking the instrument portals first. Now, why do I go for instrument portals first? It's a personal preference. But what I do is that once I take the cut, which I'll be showing you, and I put in the instruments, the pipes for the dilatation, they also act like a tamponade. It's like you scooping out an abscess cavity and then putting a pack of hydrogen over there. You want the bleeding to stop. So while you are adjusting the scopic portal, doing the white balancing and doing all other stuff, those pipes have actually stopped the bleeding that is going to occur. Other is that it's going to stretch out the skin nicely, and because the skin is nicely stretched out, again bleeding from the skin edges doesn't come through. So you have a good track establishment, you have good bleeding control, because that's going to be the larger of the ports. So you don't want that patient keeps on bleeding and losing what we call as unseen blood throughout the surgery. UBE is very notorious, gentlemen. It looks like clear fluid on the patient's back, but when you see in the collection sac, the fluid is sometimes red in color. So don't be happy. You have to calculate every RBC that you're going to lose. So the best way is to try and get good bleeding control. So I start with the 5 millimeter dilator. You can see. I'm not happy with my skin cut, my facial cut. So I take the skin, fat, then I put in the dilator, I measure the depth of the fascia. It's different in every individual. Add 5 millimeters to that, because the fascia close to the spinolaminar junction is about 5 mm thick. So let us say we have depth of 10 mm, you add 5 more. So your knife should go in only 15 mm. That way you are not cutting into the muscle. Unfortunately, people tend to describe UBE as more traumatic, and I don't know why people make such opinions and even put up such opinions, but it really isn't that. You just release the fascia and you dilate your path to the bone. As a matter of fact, you go through the entire musculature and you are stripping the fascial attachment of the muscle from bone. So you are beyond the multifidus. You are not sitting in the multifidus to tear it. So you see me nicely, gently stripping away the bone. You see there's zero effort to reach, because muscle should not give you resistance, gentlemen. Muscle should give you zero resistance. And then I will take a C-arm shoot. And now why this shoot is important? It tells me that I'm going to come nicely and vertically straight onto the area of my operation. But you can see that when I tilt it a bit, I'm coming close to the needle that I put before. Now in all this stripping and moving, the needle will have moved a bit, but that's okay. We just need the needle now for the skin marking. So you can see how nicely I've done it. And now I will leave everything there. I'm not going to remove these pipes like I explained to you. My concept is of tamponade. My concept is of controlling bleeding. I don't use anything else. I don't use an Indian knife, and I don't use that T-handle and all that stuff for dilatation. My pipes are good enough for me. Release the fascia underneath a little towards your side also, and towards the spinous process, because you need to medialize your scope. When you want to see under your facet, the scope has to be closer to the spinous process, correct? So now both the dilators have gone in. Triangulation has been done on the cranial lamina, close to the spinolaminal junction. And now I'm waiting to start my surgery. So I pick up my scope, I will do my white balancing, and I will do my orientation check. I personally, as a UBE surgeon, now do not use a 0-degree scope. I do all my work with only a 30-degree scope, because I don't want to change my orientation or visual memory bank when I'm operating a para-UBE or doing a T-leaf or other surgeries. So I prefer now to work with only a 30-degree. Now you see that we are already in the floor just adjacent to the spinolaminal junction. I'm stripping away all that fibrous tissue, these attachments of the multifidus to the lamina, the short rotator attachments to the lamina. And then I will slowly go in, and now you can see that I'm holding the pencil and just gently rotating it. Other thing that you must pay attention to is ergonomics. Your shoulders must not be up. They must be comfortable. I'm a 62-year-old man. I can't afford to work and operate like this. Sorry. I'll have to go to a massage parlor the next day. My wife would get angry. She'll wonder what I'm up to. So I focus more on ergonomics. Okay? Get the table down. Get your shoulders down. See how comfortably you're standing. Surgery is not punishment for you or the patient. It's supposed to help both. Control the bleeders a bit. Strip away. And for those who are interested now, I'm standing on the right side of the patient. The scope is in my right dominant hand, and I'm using my left hand. Ambidextrity is an art that one needs to develop. It's not difficult, because you're using a pencil, you're using a bloody burr. These are long instruments, they're very easy to handle, even kerisins. Your speed is a little slower. Doesn't matter. You don't need to try, doing everything over the top on the opposite side, because when it comes to doing a right-sided T-lift, how the hell are you going to manage? You have to go to the right. When you have to do a right para-UBE, you have to go to the right. Then why, for a simple disc, should I struggle over the top? I mean, it's easy, but still, why should I? Why should I retract the neural elements? The basic difference in what I do and what you will be seeing also is that we hardly touch the neural elements. Now this is going over the shelf. I'm going over the top of the facet. I'm going down into the interlaminar tissues. And normally in open spine surgery, gentlemen, what we do is big punch, khachak, out. We cut the spinous process, we cut the interspinous tissues, and we don't even bother about it. But this is a round, small tip of 2 mm, separating out all those interlaminar tissues in a periodic, smooth, sweet manner. It is the current that does the cutting. It's not your strength. So the first thing you have to learn in UBE is that it's a surgery that you should not be using strength. It is the current that's doing the cutting over there. I have to just touch the current to the tissue. So might as well sweep slowly, gently. And then what you notice is that I'm coming right up onto the flavum. You will start seeing the flavum the way you've never seen it in your life before, if you have not been doing endoscopies. But here you see how slowly we are stripping the phlegm. And the thin facial layer, which is between the interlaminar tissues and the phlegm. Can you see it's like a jelly kind of a tissue? That tissue is pretty stuck up to the phlegm. It doesn't leave the phlegm easily. So you slowly, slowly strip, create space on the phlegm, pushing all these tissues away. Now, why do I come cranially to caudally? Is because all our spinal muscles, all the deeper muscles, all the 5 muscles of the deep group, they all are in the direction of caudocranial. So when you strip craniocaudally, they move out of your zone. You're not cutting through them. So you don't have to do upward kerrisoning. So now see, I've used a flavel stripper. It's a small 2 millimeter instrument with a 2 millimeter front edge. It allows me to sweep under the lamina very nicely, comfortably, without even worrying that I'll go through, because the curvature of the instrument blocks you. But that stripping allows me to introduce a kerrison. Now the kerrison, gentlemen, is the same that you use, I use, and everyone uses. This is a 4 millimeter kerrison. I'm taking one big bite and bang, I've reached the flaval separation zone. You can see the epidural fat very nicely. This is the time when I remove the scopic guard or the scopic retractor, when I want to descend down into the canal, because I want to use the fluid pressure to push the dura away to the maximum, give me a clean space, clean field, no bleed, and nicely I'm coming laterally on the cord, cutting part of the facet, undercutting some part of the facet, SAP, IAP, whatever you want to call it, and then gradually using a dissecting rod to move the dural edge away. Now here we are stuck with an axillary disc. I'm going to move the dural edge away very slowly. This is the one thing I've learned to be very slow in. It's what they say, you strip a woman fast, but everything else you do later slowly. So when you expose the cord, you go slow. Now gradually exposing the bulge of the disc. Most of the discs that we come across to, if they are not in the escape zone of the PLL, then they are subligamentous in nature. It's only the upper and outer part of the disc which is in the escape zone of what we call as the PLL, and which allows a free sequestrated fragment. All fragments which are in the middle or towards the lower end plate, they're always subligamentous. And patients like these who have been working out chronically going to the gym, their PLLs have already had a reactive thickening. So you can see here with my plasma probe and a setting of 1 or 2, using only the coagulation mode, not the ablation mode, I'm cutting through the PLL. So you can see me opening up the thick PLL very nicely and gently. See, I'm an old man leaning over my patient. I'm tired out by now. 15 minutes of surgical time is too much. And then going here with a small ball tip hook to mobilize the fragment. And see, we are spinal obstetricians delivering a baby. Slowly manipulating, because obviously I'm in the axilla. I do not wish to create any form of stress on the nerve root, neither on the dura. So you can see there is minimal manipulation of the dura, absolute minimal manipulation of the dura. I'm on the right side, so obviously your axilla is on that side. This side is the caudal side. So out comes the fragment. I'll just jump the video, gentlemen. You have all seen so many disc removals, so there's nothing great to show you here. but do clean up at the end of your surgery. You can see that we have not manipulated anything, hardly moved the neural elements by a millimeter or two, removing further fragments, and you can see a nice decompressed spine surgery. What is of interesting is, this is the immediate post-op 2 weeks, the disc bulge is gone, and what I want to stress upon is, see the paraspinals. If you didn't know that I've done a right-sided surgery, would you be able to even pick up the track? But no, people say it's very destructive, it's a horrible surgery. Thank you.